Typhoid fever is a systemic, invasive enteric infection caused by the human-restricted pathogen Salmonella enterica cerevar typhi. It is transmitted primarily through the fecal-oral route, reflecting inadequate sanitation, contaminated water systems, and poor hygiene practices. The disease remains highly endemic in many low- and middle-income countries, particularly in regions with fragile water and sanitation infrastructure. After ingestion, S. typhi survives gastric acidity and invades the small intestinal mucosa, where it is taken up by M cells and intestinal macrophages. The bacteria then disseminate through the lymphatic system and bloodstream, leading to bacteremia and seeding of various organs, including the liver, spleen, bone marrow, and gallbladder. This systemic spread is facilitated by the pathogen's bicapsular polysaccharide, which enhances immune evasion by inhibiting complement activation and phagocytosis. Clinically, typhoid fever presents with a gradually rising stepladder fever, typically developing 6 to 30 days after exposure. Other key manifestations include prolonged high fever, severe malaise and anorexia, abdominal discomfort and hepatosplenomegaly, relative bradycardia, faggot sign, rose spots on the trunk, in a minority of patients, altered bowel habits, with constipation more common in adults. In severe or untreated cases, complications may occur in the third week of illness, including intestinal hemorrhage, intestinal perforation, encephalopathy, toxic delirium, and sepsis. These complications can be fatal without rapid intervention. Diagnosis relies on isolation of the organism from blood, bone marrow, or stool cultures. Bone marrow culture remains the most sensitive diagnostic method, especially in patients previously exposed to antibiotics. Serologic tests such as the Widal test are widely used in resource-limited settings but have limited specificity and sensitivity. Treatment of typhoid fever. 1. Antibiotic therapy, main treatment. Typhoid fever is treated primarily with antibiotics. The choice depends on local resistance patterns. First-line antibiotics, where sensitivity remains. Ciprofloxacin, fluoroquinolones. Ceftriaxone, third-generation cephalosporin. Azithromycin. For multi-drug-resistant, MDR, typhoid. Resistance to ampicillin, chloramphenicol, and trimethoprim sulfamethoxazole. Treatment, ceftriaxone or azithromycin. For extensively drug-resistant, XDR, typhoid. Resistance to fluoroquinolones and third-generation cephalosporins. Treatment, carbapenems, e.g., meropenem or azithromycin, if sensitive. 2. Supportive care. In addition to antibiotics, supportive care is essential. Adequate hydration, oral or 4 fluids. Nutritional support. Antipyretics for fever. Rest. 3. Management of complications. Severe cases may require hospitalization. Potential complications include intestinal hemorrhage. Intestinal perforation requires surgical care. Sepsis or shock. Encephalopathy. Early diagnosis improves outcomes and reduces complications. Shield prevention of typhoid fever. 1. Vaccination. Vaccination is one of the most effective tools, especially in endemic regions. Available vaccines. Typhoid conjugate vaccine, TCV, long-lasting protection, recommended for routine immunization. Bipolysaccharide vaccine, for adults and older children. Live oral Ty21A vaccine, taken in capsule form. Vaccines significantly reduce the risk of infection but must be combined with hygiene measures. 2. Safe water. Because typhoid spreads through contaminated water, ensure access to boiled water, chlorinated or filtered water, safe bottled water. Avoid ice made from unclean water. 3. Food safety. Proper food hygiene reduces transmission. Eat hot, freshly cooked food. Avoid raw vegetables washed with unsafe water. Avoid food from unhygienic street vendors. Peel fruits yourself. Ensure proper hand washing.